Hey everyone, this is Marshall Lemoyne with PhysioU, and today for the teaching table, I'm here with two students, Cameron and Chris, and we're going to be talking about telehealth. Is that part of the new norm? As we've all kind of been going through the last 4 or 5 months, there's been a big dip in the amount of people coming into the clinic for safety concerns, and the nice thing is we've been able to still help those patients through virtual health, so whether that's a telephone or whether that's video. There's been some good things and bad things that's come along with it. So today we figured we would do a teaching table moment on that. All right, so do you guys have any specific questions before I go over maybe more general stuff? Or?
Yeah, I guess when you think about a patient that has a high irritability and your number one goal is to calm down the fire and get them out of pain, what are your go-to interventions for pain modulation with this population?
Yeah, great question. So the hard thing is because we're not actually doing hands-on, right, which tends to be very good for pain modulation. So we kind of take that one out. So the irritable patient, already understanding that we're not going to be able to get tons of good answers from some of our tests, you say, you know what, let's just kind of push those out. Let's just go straight to what do we know can be beneficial for a patient. If I switch slides here, so we know that just positions of comfort. So if we're listening to them talk about all these things that hurt with extension stuff, so standing, walking, we can just tell them, all right, you know, let's just do exercises that are the opposite. Let's go straight into stretching into flexion. So quadruped rocking backwards, knees to chest. Go straight into positions that are opposite of what hurt them without having to test anything. Knowing that if you did test them, how reliable are they because you're doing it through a phone or a video. Some other thing is modalities, right? So whether teaching them to do hot packs or ice, stuff like that at home. They can do self-traction sometimes, right? So if it's a neck pain, we can teach them how to do towel rolls. If it's low back, we can teach them to do self-traction through towel rolls under their pelvis with their feet up on chairs. So it's more going straight down that avenue. The other thing we can talk about is education, right? For irritable patients, we can have them lay there, they can practice breathing, and we can do a lot of education, which research shows is helpful to just lowering pain. So breathing and talking to them about some neuropain science education, about the differences between hurt and harm, the differences between tissue damage and actually nociceptive pain versus nociplastic pain. So kind of stuff that we'll save for another day, but that would be the avenue I go down to see if we can just kind of calm down symptoms. Knowing at the end of the day, maybe I only really tested 1 or 2 things. And I think before we take another question, one of the benefits of the telehealth stuff is what part of your exam doesn't have to change at all. Subjective, yeah, right? If I'm doing an interview with someone in person or I'm doing it over the phone or video, I can do that exactly the same. I can actually be more thorough, knowing that my objective is going to be a little bit less. So you can kind of keep that. And that's the benefit of the virtual thing is that, hey, we can still talk to them, get all their ags, get their eases, get their irritability, get their goals, and try to create a plan based on that. And I would say because of the fact that we're limited in our objective exam, we want to make sure that you understand there are going to be some biases, right? If the referral says rotator cuff, right, tendinitis, there's not really a great way to prove or disprove that through a telephone call or a video call, right? So we kind of have to go with, well, we'll kind of assume that's what it is, and we'll go through things, and if it matches semi-close to it, then okay, we're going to treat based on that. So just kind of being open that, hey, there are a lot of assumptions, there's going to be some confirmation bias, but we can then use that information that we have from the global aspect of it to say, hey, you know what, the evidence says for these people, this is what you treat, and we treat that. So I think there's a little bit more of a generalization when it comes to telehealth because we can't prove or disprove things very cleanly. A lot of false positives, a lot of false negatives. We've definitely grown in the last 4 months in how I first started, right, back in March when we first did it to now through June, how I'm doing it, it's very different. Yeah. So hopefully that kind of clarifies some of the things.
Definitely. Yeah, I have another question, and that would be since we can't have our hands on these patients, or we can't be next to them while they're performing maybe some of the exercises that we gave them, what would you recommend to keep these patients safe, especially if they're kind of more of a fall risk?
Again, good question. You guys pulled out some of the questions that people that have been out 10 years are having to deal with, actually. And that's tough. And I'd say because, again, you're not there, you don't have a gait belt on them, you always just, if there is any issue with safety, just choose the lowest level you can. So just always plan for the safety issues. So I've had a couple of balance patients in the last week. One was an eval, one was return. And instead of challenging them with the single limb stance, expecting it to be hard, it's like, I'm not even going to test it because I don't want you to fall. So I'll pick something that's kind of easy that I know they show me they do well, and I just start to add little things to it. So the guy that does Romberg, and he looks very safe with Romberg. Okay, now start swinging your arms. Okay, now start counting backwards from 100 by threes. So you add little things like that versus this big jump from maybe Romberg to, hey, single limb stance. Right? So that's kind of one thing, because in the clinic, I would definitely jump to a harder one, knowing I can be there if you can't do it, versus at home, I may choose smaller. I'll choose the under. Another way is just making sure that they are set up in their space with as many barriers as needed. And so this is, again, one of the benefits of telehealth, is that you get to see them in their environment. So I can have them go into the corner, close the door, bring a chair in front of them or their walker in front of them. They are surrounded by 360. So a lot of times we're telling them in the clinic, when you go home, find a corner, put a chair. Here, that we actually get to see them do it, and we can test it in that environment and have them work on it in that environment. So that would be more for the balanced patient. On the other aspect, let's say we have someone with like some neurological things, right? That's actually a big safety risk as well. And so we want to be aware that we can't do a clear neuro exam at all to prove it. So are there things we can do that give us an idea of if it's positive or negative? And if it is positive, you just say, hey, it's highly recommended that you come into the clinic or you go to see someone. This is something we shouldn't be doing over telehealth. And so that would be the person that can't walk on their toes, they can't walk on their heels, right? Those all, it's like, you know what, you would benefit from being seen in person, so we can actually do a full neuro exam. So you just choose safety. Right? Any other questions from you guys? Okay. I think one of the things that I've kind of grown over the last couple months doing it is I've started taking a lot more tests for impairment to have numbers to them, because that's something we can do over video and telephone. So I can't maybe test someone's quad with an MMT, but I can definitely do a 5 times sit to stand or 30 seconds sit to stand. I maybe can't actually look at the level of Sarman's for abdominals, but I can say, hey, let's do a side plank for time or a front plank for time. So I've started to choose a lot more tests that have numbers to them. So when I recheck them, it's maybe more endurance based, but I can actually just recheck and say, hey, it's different, it's better, it's worse. There's norms for those things, which is nice. I've had a couple knees that they come in once and then their next 3 visits are all at home because they're in that age where they're a high risk for COVID-19. So we've been working on, you teach them in the clinic how to measure heel to butt with a tape measure, and then every visit they're coming in, they know how to self-measure stuff. They know how to measure extension by their kind of pushing down, and it's 2 fingers, 4 fingers. So it's allowed me to actually be a little bit more creative to teach them how to kind of measure it themselves, and then it's actually probably made them more compliant because now they know exactly what to kind of look for at home, more clear than with a goniometer for what we would do in clinic. All right, so to finish up, some of the benefits of telehealth is definitely the convenience, right? They've actually been doing telehealth visits in 2001 with the VA, so almost going on 2 decades, because ex-veterans maybe don't live near a VA hospital, but they get services there and they may live 100 miles away. So it's quite inconvenient for them to drive 100 miles for a PT session. So they've been actually doing it for a long time, and they have really good results with it. So it's nothing new, it's just become much more common. So the convenience is amazing. As I mentioned, we get to see them in their environment. So in their home, they tell you it hurts when they sleep. We can say, hey, show us how you sleep in your bed, right? Versus on our little plinth sometimes, where they sit in their office chair. Show us. So I like that. And then it puts a little bit more emphasis on them, right? Kind of like the measuring the knee person, right? We're not there to able to do mobilizations or soft tissue or to do stuff for them. So they actually realize, hey, this is all on me. You're going to help me, but I have to do it. Issues, some of the concerns like you guys brought up. Safety is a big one. Our exam is not the same, right? We cannot gain nearly as much information. In some places, are you able to get paid for it as physical therapists? Are we able to get reimbursed from it? And then licensure. If we're in California and your patient's traveling to see his mom in Nevada, technically, hey, we could do a telehealth video no matter where you are, but the laws are very different, right? The physical therapy laws in Nevada are different than California, and so there's kind of some issues that we want to make sure we're aware of with that. Yeah, I think that's it for telehealth. Again, it's something that we are all doing a lot more of, and even when all of this calms down, it's something that I think will still be a big part of healthcare due to some of the benefits of it. Take care, guys, and hope to see you next time with the Teaching Table.